I'm joined today by Maria Weaver, the Associate Director, Suicide Prevention and Life Promotion at CMHA-BC Division. She is a skilled and enthusiastic leader, educator, and facilitator with many years' experience across sectors, including higher education, nonprofit, and community health. With her experience working frontline and later managing a crisis line, she's adept and compassionate in providing crisis de-escalation, mental health promotion, and suicide prevention training and education. If you have any questions, please use the QA box and your questions will be answered at the end of the webinar. Thank you, Maria, for joining us today, and I'm going to turn it over to you now.
Thank you so much for joining us today, and thank you for having me. I'll wait to get host privileges, and then I'll pop some slides up on the screen for us here. Awesome. All right. All right. And Siboney, are you able to confirm you're able to see my slides okay?
Yeah.
Awesome. Perfect. Well, thank you, everyone. As Siboney said, we're going to be talking today about responding to crisis at work. So really intended to be kind of an overview of some tools that we can put in place to respond to moments of crisis or distress in our workplace. You may have heard Siboney mention this in the introduction and may have also seen this kind of in the blurb about today's webinar as well, that I want to be really clear right at the outset. I know many of us might be coming to today's webinar from kind of healthcare roles or roles where you might be in kind of more of a mental health support person capacity. So want to kind of really at the outset let folks know that this really is intended to be an intro. There's lots of great things we can take away from today's webinar, but our learning today is definitely not intended to replace any kind of more thorough crisis de-escalation training. So at the end, we'll also go over where you can go for kind of some further learning. I also hope that this webinar, for those of you that may have attended the one that happened a little while back, there's another kind of responding to crisis de-escalation topic that happened back, I believe, in April. So hoping that this could kind of build on some of the great learnings and tools and resources that were shared during that webinar as well. So really making sure we're on the same page here. What are we talking about when we say crisis? Really what we're focused on here is any event or period that may lead to an unstable or dangerous situation. And this can really range. So we might be talking about somebody, a client or a patient that we're working with that might be a bit upset, all the way through to somebody who might be kind of presenting a more intense presentation of crisis. So really working kind of within that full broad range there. Siboney also already gave an introduction to who I am, so I'm not going to kind of belabor the point of introducing myself, but just wanted to kind of highlight that the work that I do with CMHA does focus kind of more broadly on suicide prevention and life promotion. And you might be wondering, what's the link here? A lot of my role does also focus on kind of education, training, facilitation in the community. So doing workshops and webinars like the one that I'm bringing to you folks here today. I did want to take an opportunity, though, to I know it's a bit odd in webinar format. I know you're out there. I can't see you or hear you, but I would love to get a chance to kind of get a better sense of who we have in the Zoom room, if you will. So I've got a quick set of polls here that I'm hoping folks can respond to. I'll just get this launched here. So the first poll that we have here, just asking whether or not folks attended the earlier webinar. So just trying to get a sense of how many of us may have kind of already experienced the session before. Awesome. Give a couple seconds there. Got a couple answers still rolling in. So it looks like the majority of folks know. We've got with a kind of peppering of folks that perhaps did attend that webinar. So we're going to end this poll here. So just sharing the results for those that are curious. Great. So for those of you who did not, who may not have kind of explored this topic before, great. There's going to be hopefully kind of lots that it's new and helpful that you can take away. And for those who did attend the earlier webinar, I will kind of try to bridge where I think some of the learnings of that last webinar might be kind of most handy in what we're talking about here today. Next question for you folks. I'm curious how you would describe your role at work. So I've got a couple options. If you feel like none of these land for you, feel free to tick that other box, but kind of really curious where folks are kind of coming to today in terms of kind of background. Looking like quite a mix here. Give a little bit more time for folks to kind of fill that in. Lots of management, leadership, lots of other, and also some folks kind of in frontline healthcare roles. So we'll share those results there for folks to get a quick look. Yeah, so awesome. Great to know. I'm very curious who the others are. I wish I had a chat feature so I was able to know. But so we can see there's quite a diversity of folks in the room. And I think that really speaks to the fact that this topic really does touch all of us. So really great to see kind of such a breadth of folks participating today. One more thing, and then I promise I will deliver some content. I'm curious how this type of work shows up in your role. So we've got a statement here: I provide comprehensive mental health support to people I work with. So are you somebody for whom providing actually that formal mental health support is a part of your role? Perhaps yes, maybe not so much. Maybe you're doing it, but it's not actually in your job description. Maybe you're not doing so much of that, but you're maybe, say, in a leadership role and you're providing mental health support to colleagues, et cetera. So kind of trying to get a sense of where folks are coming from in terms of how much of these skills are being used on the job or are kind of integrated into your job description. Great. All right. Awesome. So it looks like for the majority of us, we're not necessarily going to be in those formal healthcare helping roles. That's great. This webinar, honestly, will fill a lot of that need, I think. And then for those of us that are providing that comprehensive mental health support, especially those for whom it's not in your job description, definitely I'll highlight some of those resources at the end where maybe some opportunities for further learning as well. Awesome. So thank you for humoring me. This is actually the first time I've used polls in a webinar, so I'm glad that went off without a hitch. And there will be some more coming during the webinar as well. So stay tuned. So many of you might know who CMHA is already, but I know before I worked for CMHA, it's a name we hear often. We're not always sure, though I know I was not always sure what CMHA did. So I always like to hold a little bit of space to kind of give just a quick overview of kind of what we do as an organization. We are a federated model, so CMHAs do exist all across the country. And here in BC, we operate the BC division, so that's where I work. It's our provincial body, as well as 14 local branches that serve over 100 communities to meet local needs. So for some of you, you might have a local CMHA branch in your area, so definitely if that's something you're curious about, I recommend you check out the website cmha.ca. And just generally, CMHA delivers a lot of different services. What we do in different areas varies really to meet those community needs. But at the provincial level, we offer kind of a mix of education and training. So like what I'm doing with you folks here today. We do frontline service delivery. So we do actually have programs that serve members of the public. And the cool thing about being part of provincial division is that we do also work alongside government to do some policy and advocacy work as well. So sometimes people think we are government. We're not government. We are a registered charity, but we do work very closely with our provincial government here in BC. And finally, before we launch into some content, I did want to highlight a couple of resources that are available for immediate support in British Columbia if folks are needing it. We have here 2 wonderful lines that are answered by our regional crisis centers in BC. The first is 1-800-SUICIDE. That's a kind of high urgency line that gets you access to somebody right away, available 24/7. And we do also have 310-6789, so a general mental health line. And there is no area code for that number. So if you're wondering kind of where did the other 3 numbers go, you just type it in just as it is there. Awesome. So where are we headed today? We're going to be starting off by just kind of painting a picture of mental health, substance use, and homelessness in our community. And I'll kind of tie into why we're talking about that as we get there. We're going to move into talking a bit about stigma, the model that we'll be learning today, knowing our limits as helpers, and ultimately how we can support our staff and ourselves, and then finishing off with some resources and question time. Like Siboney said, if you could please put any questions you might have in the chat or in the Q&A feature. Anything tech related will be answered right away by some of the lovely folks who are on the line to support with tech, and anything related to content we'll be addressing at the end there. So whenever we're having these conversations, I think it's really important for us to differentiate between the concept of mental health and mental illness. And for many of us, we may have heard these terms being used interchangeably. But what we know is that these terms are actually not one and the same. So when we're talking about mental health is actually a state of well-being. So it's something that we all have. No matter where we are in our own mental health journey, we have some degree of mental health at any given time, just in the same way that all of us experience physical health in some way. Mental illness, on the other hand, is what we would call a disturbance in thoughts, feelings, and perceptions that are severe enough to affect day-to-day functioning. And mental illness, as we know, often requires the diagnosis of a clinician or a physician who's able to kind of sign off on that. So why highlight the difference? One of the things I hear sometimes, and this is something if you are leadership, maybe this will land in a new way. If you're somebody that works with somebody that may have a differing perspective from you, here's a tool you can use in these conversations. We often hear people say, oh, well, we don't deal with mental health in my workplace because we don't have mental health here. And what we know is that everybody has mental health. So whether or not you believe that there's maybe mental illness in your workplace or mental health challenges, no matter who we are, no matter where we're working, mental health, just as physical health and safety is very important and impacts all of us, mental health and psychological health and safety impacts all of us in that same way. So how prevalent are mental health challenges or mental illness in our community? In BC, we know that mental illness will affect 1 in 5 people in any given year, which comes up to almost 900,000 or close to 1 million British Columbians. So that's just a snapshot in time as well. That's in a given year. When we actually zoom out a little further, by age 40, 1 in 2 Canadians will either have or have had a mental illness. So really impacting almost 50% of us. There was a study that came out during the pandemic as well that 41% of people in Canada actually reported a decline in their mental health since the onset of the COVID-19 pandemic. And this decline was notably more pronounced for what the study defined as being vulnerable groups. I don't super love that language, but really what they're trying to get at is folks who may face other barriers to accessing service safely. So for example, folks who might have pre-existing mental health challenges, or folks who might face systemic barriers. So for example, queer or trans folks, BIPOC individuals, etc. In the same UBC study, it was interesting to learn that 1 in 5 people living in BC said they needed some form of help with their mental health during the pandemic, but were unable to receive that help. And what I loved about this study is they actually dug a little further to find out, what was going on here? Why weren't people able to get access to the support that they needed? 35% of these individuals said that they didn't know how or where to get help, so perhaps didn't even know where to start. 41%, there was a financial barrier, so couldn't actually afford to pay for the help that they needed. And 37% found that access to care was limited. So that might look like long wait times or perhaps being in kind of rural or remote areas. For those of you on the call that might be math nerds like I am, you might be adding up those numbers and thinking, oh God, Maria's made a typo. These don't sum to 100. What's going on here? This is not a typo. I did receive some feedback on it in my first time doing this webinar. The reason that those numbers can sum to over 100 is because folks can actually have ticked more than one. So they may have experienced more than one barrier in accessing care. So when we're talking about crisis, when we're talking about mental health, we often hear kind of substance use tied into the discussion. And there's a reason for that. Definitely folks with substance use disorders can be up to 3 times more likely to have a mental illness. But I want to be very clear that these two things are very different as well. So not everyone who's using substances has a mental illness, and not everyone who has a mental illness is using substances. We do know, though, that about 1 in 5, so 21% of Canadians will actually meet the criteria for addiction in their lifetime. And as we know in BC, the opioid overdose crisis has really been impacting quite a number of folks here in our province. Approximately 70% of these individuals were employed in some capacity in the years leading up to their death. And what we know is most opioid deaths are actually occurring in private residences. We often hear in particular from those of us who might work kind of in the downtown area, maybe in businesses that are kind of nearer to urban centers. The topic of homelessness will often come up when we talk about crisis. And again, these two things can intersect. They don't always. I've highlighted some stats here from Vancouver. I know not all of us are coming from Vancouver, but these are kind of the most, I think, pronounced statistics out there. I've also just been informed these stats have been updated as of about 2 or 3 days ago, so I will be updating that moving forwards. But the stats we're looking at here come from March 2020, where we found that about 3,634 individuals in the Metro Vancouver area were experiencing homelessness. This point in time count that occurs every few years is great because rather than just kind of going around and counting the number of heads, these folks actually also get to hear the stories of the folks that are experiencing homelessness and really learn more about kind of who they are and what their background is. And what really stood out to me from these data is that more than 1 in 3 of these individuals were previously in the foster care system, so in some kind of government-supported care as youth. And many of them actually first experienced homelessness in the month after aging out of care. So being no longer able to access those youth government services, trying to transition into adult care, and something slipping there. 43% of these folks experienced homelessness before the age of 25 for the first time, so at quite young as youth. And 21% of folks were actually employed in some capacity. We also know that BIPOC individuals are massively overrepresented in data around homelessness. Although only about 3% of the Vancouver population identify as Indigenous, 33% of the folks that were contacted through this study were Indigenous. And we can see the same theme reflected for Black, Latinx, and Arabic communities as well. And I want to be really, really clear when we're talking about stats like this, there's nothing inherent to these groups that makes somebody more likely to experience homelessness. What we're really looking at here are the impact of systemic barriers and things like racism, colonization, et cetera. We also know through this point in time count that approximately 90%, so almost every single person that was talked to through this study, reported having at least one major health challenge. So 23% a learning disability or cognitive impairment, 36% a physical disability, 50% a mental health challenge or mental illness, and 60% struggling with addiction. And again, these numbers don't sum to 100 because folks may be experiencing more than one of these things at a time. So at this point, you might be wondering, what on earth have I signed up for? Am I here to just listen to somebody talk about statistics? No, that is not what we'll be doing for the rest of the day, but there is really a reason why we bring these statistics up. And you may have perhaps noticed that one of these topics perhaps left you feeling a bit uncomfortable. Maybe some of these statistics surprised you. And really the reason why I highlight these stats is it kind of gets us thinking about maybe disrupting certain narratives we have about certain topics or groups. And a lot of that can come from what we call stigma, which is a negative and often unfair social attitude attached to a person, a group, or a topic. We do a really good job, I think, in our society currently about talking about the way that stigma can actually impact those of us asking for help. So we talk a lot about the fact that stigma can make it harder for us to speak up, harder to talk openly about issues, harder for us to ask for help. Maybe we're worried how people will react. But what I think we talk about a lot less often that is really at the core of responding with empathy is that stigma can actually make it harder for us as the helpers to respond non-judgmentally to a situation. So let's take, for example, the example of homelessness. Again, not saying that every time we encounter somebody who's experiencing homelessness that they're going to be in crisis, but we might enter an interaction with the inherent belief that everybody experiencing homelessness is violent, which as the helper, I may then show up in that situation automatically guarded, automatically quite activated, automatically quite fearful. And so thinking about the ways that kind of how we show up in conversation, how we show up in helping roles may actually impact the way we're bringing our emotions, our feelings, our responses to scenarios. And I don't say this because I'm expecting everybody to leave, a 45-minute webinar and be like, oh, wow, I'm stigma-free. I'm never going to have an emotional response again, or never going to have a stigmatizing belief. But rather because so much about de-escalation and so much about responding with empathy is kind of about our own self-reflection and self-work, which is something I know we never like to hear. But so much of it is about that. And so it's just a point of reflection for us to kind of keep checking in on as we kind of move forward. So really, as we're talking about stigma, we know that crisis can be related to any of these things, can be related to mental health challenges, substance use, and homelessness. And crisis can really, happen to anyone. So anyone can be impacted by things that may lead to crisis. Any of us might experience crisis. And what we know is that everyone is deserving of support. And so really the bottom line is we don't always know why someone might be acting the way they are, but what we're responding to is the behavior. So that takes us to the model that we're going to be learning today. And these are kind of 3 simple steps that we can follow to assist someone in distress. And that's ask, listen, and refer. So the first thing we might be doing here in this ask phase, it's very similar to when we think about physical first aid. We want to notice signs of distress. We want to notice when somebody might be experiencing distress. Where are we comfortable intervening? Is it safe for us as a helper? What are some signs of distress where we might not be comfortable intervening? Where might it not be safe for us as helpers to intervene? And we want to be mindful, again, during that kind of assessment of whether or not we want to intervene, whether or not someone is in distress, mindful of assumptions that may come from stigma. So when we were creating this webinar, we actually were doing it in partnership with the woman who owns, if any of you are from Victoria, there's a nice Italian restaurant in Victoria called Il Terrazzo, and their owner, Shelley, lovely woman, was helping us with this webinar because she was really hoping to get actually her servers and hosts trained up in some skills of how to respond empathetically. And she shared an example with us of a time where a gentleman came into her restaurant and he was dressed in a way where the staff kind of perceived that perhaps he was going to cause trouble. They didn't really, they're like, no, we don't, he's not dressed like our usual clientele. We think he's in distress. We think he might be violent towards other patrons. And they actually approached the owner and said, I think we need to kick this man out. And Shelley was really great because she asked back, has he done anything? Is there anything this man has done that's suggested that that's the case, or is it just the way he's dressed? And the hosts were kind of forced to reflect and say, actually it was just the way he was dressed. And this man ended up coming in, sitting by himself, having a lovely dinner, paying for his Italian food, and being on his merry way with absolutely no impact on the patrons or the staff around him. So a situation in which intervening in that case may actually have escalated and been based off of a stigmatizing assumption. So if we're not already in conversation with somebody, the best way to start that conversation, to check in, to see how somebody's doing, is just to ask. And we don't have to ask in a way that's overly complex. It's easiest just to ask in a simple and explanatory way. Hi, I'm Maria. How are you doing today? Hey, I'm getting the sense you might be feeling overwhelmed. What's going on for you? Or what can I do for help? We don't want to assume that we know what someone needs. I know for many of us, hearing the statement, just calm down, is like, oh, not something we want to hear. But we often, very well-intentioned, we will often give suggestions right off the bat. And a lot of the time, people don't want to hear that necessarily right away. So really kind of allowing that space for open conversation. Our body language is also really important. So for example, if somebody's low to the ground, maybe somebody's crouching or sitting down and we're kind of standing over them having the conversation, we may not mean it to come off as threatening, but being able to come down to that person's level if it feels safe to do so can really kind of level that playing field. We also want to be conscious of not blocking folks' exits to our space. This is a thing that we don't always notice, that it leaves us feeling kind of with our backs up, but I've noticed this even with colleagues who are lovely. To be very clear, I work with very lovely people, but even when I'm in my office and a colleague kind of stands in the doorway, there's a part of me that automatically clocks the fact that my access to the space is blocked. So being conscious of kind of making sure that some of those unintentional kind of physical barriers aren't in place. For those of you who are in healthcare settings, if somebody's unresponsive, you will likely have some very clear medical protocols to follow. If you were a civilian in the public, though, and you came across somebody unresponsive, really in the past, we used to recommend things like going up to somebody and shaking them or poking them, and we really don't recommend that anymore. We know that that can be really violating for somebody and could potentially be unsafe for you as the helper as well. So what we would recommend in this scenario is really just a call from a distance. Hi there, just wanted to check to make sure you're okay. Maybe they don't respond right away. Maybe you raise your voice a little more, maybe get a little bit closer if that's safe. But ultimately, if somebody's unresponsive, this is a scenario in which obviously we're skipping the listen step altogether, and we'd recommend calling for help immediately. So assuming, though, somebody's willing and able to talk with us, we're actually able to engage with somebody who's in crisis, it can be immensely powerful to just listen to them empathetically and without judgment. So really just holding that space. So what does empathy look like in practice? I'm actually going to turn things over to my video co-facilitator for today, Brene Brown. So this is a video clip by an author and professor of social work that folks may know. She's done a lot of work kind of in the mental health and in the social services sphere. But I'm going to play this little clip that really is going to demonstrate for us kind of what is empathy and how does it contrast with sympathy.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
All right. So that is one of my favorite video clips. I've watched it a bazillion times, but I swear it never gets old. And I think it really packs a punch to hear some of those at least. And they're totally well-intentioned. We're often, like Brene says in the video, we're often trying to silver lining, we're trying to problem solve. And that comes from a really good place as helpers. We're really programmed in our society, especially those of us that are quite keen and really passionate about what we do, passionate about helping. But sometimes really what we need to do is actually just sit with somebody in that discomfort. And so what does empathetic listening look like? What we're really aiming for is to be present with someone, both in mind and in body language. So how might we show we're present? Again, thinking about body language, speaking more slowly, using a softer tone, thinking about some of those things we talked about before, where we're at somebody's kind of eye level, we're not blocking way out of space. And when we talked about kind of being present in mind, we're also talking about kind of what we talked about before when we were reflecting on stigma and how that can show up. Being angry, frustrated, or anxious can really get in the way of listening with empathy and really potentially lead to an escalated scenario. So what do I mean when I'm saying that? We're going to use an arbitrary escalation scale, and I'm just going to use my hands. Very low budget demonstration here, but I think it gets the point across. When we're dealing with somebody who may be in an escalated state, we often imagine that they're coming into the conversation at an intensity level 10, say. And if we come in and we match them, say we're angry, maybe we're frustrated with them, and we match them at their intensity scale, what we know about humans is often that person's going to feel threatened by that, and they're going to kind of bump a level up. They're going to bump up to maybe a level 20 intensity, basically out of kind of that feeling of threat, out of feeling trapped. And we will notice that, and what we will often do is we will often kind of bump our intensity to meet them. And what we start to do is we start to kind of climb this ladder together where we're both kind of escalating in tandem. What we're aiming to do when we're showing up in this empathy space, when we're showing up kind of calm, present as much as possible, they're coming in at that 10, but our goal is to meet them back at 0. And what we know is if we're able to stay in that 0 place, it's much more likely that they're actually going to drop down to meet us there. Now, I say that not to kind of say that this is an easy skill to learn, that this is always going to be the case, that, we're never allowed to be angry, frustrated, or anxious again. Absolutely not. These are normal human emotions. They're always going to come up for us. But again, like when we talked about stigma, it's something for us to reflect on, for us to check in on with ourselves. When we're about to engage in a difficult conversation, you know, how am I feeling internally? What can I do to take care of myself so I'm able to show up in a good way in this conversation? And maybe even I'm not able to take care of the feelings I'm having right now, and I'm not the best person who's going to be able to have this conversation effectively. Who else can I tap in that can support me through that? So lots for us to kind of be thinking about. It can also be a really great way of expressing empathy for us to use what we call reflective listening. So reflecting back the content and the feelings of what somebody's shared with us to kind of confirm understanding. And reflective listening, empathetic listening on its own, this could be like I actually think there's a course in university, if you do a master's of counseling, that largely focuses on this topic area. So know that this is a topic we could spend a lot of time discussing, but something that's a tool that, you know, if you're interested, I would really encourage kind of further learning in that area as well. And really, again, like we said, leaving some space for sharing before jumping into problem solving to hopefully allow for some of those discharge of emotions. So what might this look like? Somebody in distress might tell us, you know, I'm just so angry. I was laid off yesterday and I feel like a failure. And instead of saying something like we saw in the video where we say, oh, well, you know, at least you're smart, you're going to get another job, we might just sit with that person in that discomfort. You know, wow, I hear you. It sounds like being laid off has left you feeling so upset, maybe even disappointed in yourself. Really allowing that person that opportunity to feel heard, which can be a weird place for us to sit in as the helper. It does take practice to kind of develop that comfort and not fixing or solving. So we're now at the part in the webinar where you're going to have to listen to me awkwardly role play with myself, but I've got a couple examples that I just want to walk through with you folks. And the first example here is imagining that a patient has come into our office. They're upset because they really wanted to book a same-day appointment, but they're not able to do so. So you might hear the patient say something like, what do you mean I can't get in today? This is serious. And we might respond with, I'm so sorry. I wish there was something I could do. I totally get why you're upset. Waiting for healthcare can be an awful experience. Yeah, honestly, it has been. I don't even understand why I can never find help when I need it. I hear you. It's so infuriating when you're trying desperately to get connected to support and it seems like you keep hitting dead ends. Yeah, honestly, that's exactly it. What am I even supposed to do? I'm definitely open to exploring other options with you. What do you think? Okay, sure. I'm open to that. So in this scenario, you can see that this patient, there was kind of that underlying need of needing to be heard about how frustrated they were about, you know, the delay in getting access to care. Was their request unreasonable? Yes, absolutely. Did we as the responder have to compromise that boundary? No. We were able to just sit with this person, allow them some space to share their feelings, and ultimately bridge them into exploring other options. You might at this point be looking at the way this is worded and be like, oh God, I would never say something like that in those words. That's okay. This is how I might say these sentences. This is how I might work through that scenario. But what these tools are going to sound like in practice are going to be very individual. So it can look very different person to person and interaction to interaction. So we've got another example here. Imagine we've got an individual kind of wandering around our office space. They're engaging with other patients in the space, and you can tell that they're leaving other patients feeling quite uncomfortable. So you might start the conversation by saying, hi there, I'm Maria. I work here as an administrator. How's it going? And this person might respond to you, terrible. Everything sucks lately. Oh, wow. It sounds like today's been pretty rough. Yeah, always. I have nowhere to go, nothing to do, just got kicked out of my place. Wow. Yeah, I can imagine how horrible that is. Sounds like you're feeling pretty gutted right now. Yeah. With all this stuff going on for you, I'm wondering, is there anything I can do to help? I mean, I don't know. I kind of just need somewhere to go. I'd be happy to look at some options with you. You're welcome to hang out here for a bit while we look, or I can give you the number for a warming space nearby. If you do choose to stay here, I'll just have to ask you to make sure not to disturb our other patients. Lots of folks here are working right now, so it's important that we respect and give others space. What do you think? Okay, sure. I guess the number would be nice. Thanks. So again, in this scenario, we're obviously concerned that this person is kind of in the space and maybe not necessarily supposed to be in that space. One way of responding, we might have gone right up and said, hey, sorry, I've got to ask you to leave. And that might have put that person in that further escalated space. So what this person did instead, what the staff member did, was kind of sit with that person in that discomfort, sit with those feelings, and then gently bridge, again, not compromising boundaries, not compromising the fact that this person had to stop the behavior of disturbing other people, but allowing that conversation to kind of unfold with empathy. So in the context of what we've just talked about, in the context of the level of skill we're talking about in this workshop, our role as helpers would not be to provide comprehensive mental health support within the context of what we've just learned. If you are somebody whose role is to provide comprehensive mental health support, again, just a reminder, we'll talk about where you can go for further learning, but within the context of this webinar and this model, after allowing space for that listening, we ultimately want to be referring that person onto further available resources if needed. So if they've de-escalated, if they're kind of in a place where they're able to have that reasonable kind of rational conversation with us, we may want to provide them with additional resources if they kind of want that, or they feel like that would be helpful. We don't have to, though. If somebody's disengaged, they've left your space, you don't have to go running after them with pamphlets, but for some folks, it might be helpful to get those additional resources. If, on the other hand, you're in a situation, you've tried some of these skills, you're really trying to be patient, you're really trying to use empathy, sometimes, it's not always going to work, and that's okay. That's not a failure on our part as the helper. Sometimes we just need that additional support. And so if somebody's really not de-escalated, if we're starting to feel unsafe, we may want to involve additional resources that will be able to offer more urgent support. And we can look at what that looks like as well when we talk about resources. As we saw in those examples as well, it's totally okay to set boundaries with people. It's okay if somebody's being disruptive to ask someone to leave. You might say something like, it's been great chatting with you. I've got to go back to work now. I'm unfortunately also going to have to ask you to step outside to make space for our other patients. Or even you can use, I know that there's some COVID numbers spiking again, so maybe we use that as an excuse. We say, we have a limited number of folks we can have in our space. Would you mind if we continued this conversation outside? So a couple ways that we can kind of set those boundaries. Knowing our limits. So really, really important as helpers. We want to, I know it's kind of like a cliche phrase, but we always hear this term, put on your oxygen mask before putting on another person's, or make sure your cup is full, because if your cup's not full, you can't help someone else. It's so true. It is so important for us to keep that in mind. And so we need to know as helpers that there are times where asking and listening and referring is going to be a really powerful series of tools for us. But there are also going to be times where it's just not safe for us to engage with someone, and that's okay. We want to encourage you to make sure if that's happening, again, it's not a failure on our part as the helper. Sometimes we do just need to move on to that refer bit and call for help instead. So within the context of different workplaces, this is always going to look a bit different, but you may kind of want to think through when you might want to call in for backup support or additional help. So sometimes when we might want to be skipping the model altogether and getting additional support regardless, we might want to be asking questions like, is anyone here in immediate danger? Are you in danger? Is the person in danger? Are other people around you in danger? Are you alone? Maybe you have a work alone policy. Maybe you're not comfortable interacting in this way alone. Is there a weapon involved or anything else that could cause bodily harm? And really more subjectively, do you feel unsafe? And when in doubt, really, again, encouraging that it's always safest to call for support. We talk a lot about this idea of calling for support. And again, that's going to look different in different workplaces logistically. But what we don't often kind of talk through, and some of you may have these policies already, which is amazing. Many of us maybe don't have this already, but what do we do to keep ourselves and others safe after calling for help? So maybe you have somebody who's gotten quite upset. Maybe they're displaying violent behavior. You've called for additional support, and now you're just like, okay, now I'm waiting for the backup support. What do I do? And I would really encourage that this be, if it's not already a conversation in your workplace, that this be a conversation that you have with your teams. What would work for your workplace? Can you co-create a plan? Can, for example, staff leave the premises? What does that look like? Many folks will have had interactions like this before. And so folks, colleagues of yours, even yourselves, might have examples of things that have really worked in the past and other things that you're like, you know what, this really didn't work and we need to avoid this. And how can we support each other? How can staff support one another? So for example, if you see a colleague in an unsafe situation, what can we do to support each other? One of my first jobs was actually at a medical office as a medical office administrator. And I had a situation where I was not skilled in these tools at that point in my life. And I had an interaction with a patient that got quite escalated. This person ended up becoming quite violent. They were throwing chairs in the waiting room. Like, it was quite frightening. And I did end up having to call for further support. Through this process, I was alone. I would have been like 19 at the time. I was quite frightened. There's a plexiglass barrier between the two of us, but it's not very strong. This person was quite a bit bigger than me, quite a bit more aggressive. Help ended up arriving. This person was escorted off the premises. And after this happened, a whole bunch of my colleagues came out from behind a hallway and started kind of like applauding and were like, oh, well done, Maria, you handled that great. And I was kind of like, oh my God, you know, multiple people, including medical doctors, saw what was unfolding and did nothing to intervene. And at the time, I was just quite upset about it. I felt a little bit jaded, like, you know, why was I alone? Why didn't anyone think to step in? But as I've gotten further and further away from that scenario, the more I reflect on it, the more I believe what happened was actually a structural failure. We did not in our workplace have a policy on how to deal with violence in the workplace. We did not have a plan for supporting one another. And for many of us, when we see crisis, when we see danger, when we see, you know, activation, we can freeze. If we don't know what to do, if we haven't pre-prepared how to support each other, we might not know what to do in that moment. And so now I don't blame my colleagues for not intervening. Would I have liked somebody to be there? Absolutely. But I truly believe that what happened there was people just didn't know what to do, and so they did nothing. And so I really think that highlights the importance of actually having these conversations within the workplace if they're not happening already. The great news about this model is we can also use it in supporting our team members. And also we always want to be remembering self-care. So we'd be remiss to do a mental health workshop without a little bit of a focus on self-care. So after dealing with a situation that's difficult, we ourselves and our team members will likely be needing support as well. So the great news for those of us on this call who supervise staff or who are in management and leadership roles, you can actually use this same model with your staff too. You know, hey, John, that looks like a really intense interaction. How's it going? Allowing that space for listening, that validation, and then making John aware of what resources are out there. That might look like resources internal. Maybe you have an employee family assistance program. Maybe you have an on-site counselor, like lots of different things we might have in our workplaces. And it can look like additional support too. You know, John, you know, I'm really worried about you. Would you be open to exploring some places that we can get you connected to further help? So making sure to bridge that connection as well. And then thinking about self-care, like we said, supporting somebody in crisis or even supporting a staff member can be really challenging. It can be draining for us to be kind of giving that support for those of us that are doing it quite often. And so I would really encourage, you know, now and into the rest of your afternoon to reflect on what self-care looks like for you. And I always like to think of it kind of in two buckets. What does self-care look like for you at home? What are the things that you do for yourself in your personal life? But what does self-care look like for you at work as well? Do you work in a workplace where you can take a walk over lunch, for example? Do you have little practices that you put in place with your colleagues? I know we've started doing kind of a donut Thursday type of situation at CMHA here at our Victoria office, where a person offers to kind of, we split the cost amongst us to go buy donuts. And it's like a little thing, it's a gimmicky little fun donuts, but it honestly does make a difference. And there's some really good donuts in Victoria. So definitely like things that we can be thinking about both in our personal lives, but also in our work sphere. So as we wrap up, I just want to highlight some resources that are available to us here in British Columbia. First on the list here, we do have 911. For those of you that may be embedded in a hospital setting already, obviously you have care providers on site too. But just a reminder that if you're kind of interacting with somebody and there's been kind of bodily harm that's occurred, making sure somebody gets connected to healthcare is very important. So 911 is going to be kind of our first option in those scenarios. Otherwise, though, if bodily harm has not occurred, we've got lots of other wonderful options available to us in BC. We do have 1-800-SUICIDE. That's that 24/7 number that's accessible throughout the province. CMHA has been working as well with a variety of care providers across BC to launch what we call peer-assisted care teams. This is a mobile crisis response team that pairs a clinician, so a counselor, a social worker, someone like that, with a peer support worker, so somebody who has lived or living experience with mental health challenges or with substance use. So these teams are operational right now in the North Shore of Vancouver, in New Westminster, and in Victoria, but there are more launching in the next few years, so do keep an eye out as well. If you're not located in any of those three centers, know that there may be one coming to you soon as well. There are also kind of some other mental health response teams out there as well. They're often under the name of CAR. So those of you in Vancouver may be familiar with these CAR programs. They exist in various parts of the province. And they are often run out of kind of local police departments. So if you're curious if you have a CAR program in your area, there's too many for me to list them all. Just search CAR mental health response team and then your city name, and that should bring up results for you. The difference between the PACT and the CAR, they're both very similar in that they both respond to mental health responses, but CAR has a different service provider complement. So CAR is a police-based team. So you will have a often plainclothes police officer responding to calls through CAR, and paired with often a psychiatric nurse. So a bit of a different team complement there. Some additional resources, as promised, we have obviously our website if you want to learn more about the work we do here at CMHA BC, but I've also included a site that we run in partnership with some other organizations, BC's Hub for Workplace Mental Health. So if some of those pieces, particularly around supporting employees, kind of flagged of interest to you, definitely recommend you check out that website and our website and other training offerings as well. These pieces here are kind of more what I was talking about as well, about further learning. Really recommend those of you for whom you're providing comprehensive mental health support and you're really wanting to kind of get more of those hands-on de-escalation tools, that you're connecting in with either the Crisis Prevention Institute or your local crisis center. We do have at least one per regional health authority. So these resources will be, I understand, distributed to you later as well. And then of course, you're all here because of some form of connection to Care to Speak or Care for Caregivers. So definitely recommend using that resource as needed as well. I just have two final polls that I'm just very curious as we're kind of going through these resources. I'm curious, and this is partially for my own learning, but partially because I think it's an interesting thing for us to look at as a group. Really curious whether or not your workplace has a written policy or procedure kind of detailing how to respond to crisis. So I'm just going to launch that poll here for you folks. You'll notice here as well that first option is that yes, you have one and your supervisor explained it to you. The second is yes, you have one, but you did not receive any explanation or training on the policy. We'll just give a couple seconds for that to come through. All right, I think that's most of us. So very interesting. I'm very heartened to see that most of us on the call do have a policy in place and we're actually received some training. But of note, I think it's really interesting to see that many of us, the other 50% of us, either have one and didn't receive training, don't have one at all, or aren't even sure if there's one in existence or not. So really something to flag if you're one of those people in the kind of those last three categories there, and you are in a position, especially if you're in a leadership role, would really encourage folks to maybe start that conversation and flag that this is something that's impacting staff and that may be worth conversation. Got one last poll and then we'll move into Q&A. The last piece I'm curious about is whether or not you have been provided with any kind of crisis de-escalation or empathetic response training. So either yes, it was mandatory, yes, it was optional, or no, this is not a form of training you've received before through your work. Give a couple seconds for that to unfold. All right. Great. So fairly similar to what we saw before. For most of us, it looks like, again, I'm heartened to see that almost 48% received training and it was a mandatory part of the role. Surprised again, though, that for over half of us, either yes, it was received, but it was optional, or no, not at all. So again, another thing, especially for those of us in leadership roles that may have that decision-making sway, something to think about moving forwards, whether or not this is something that's needed in your workplace and whether or not you have the ability to kind of start that conversation and get these resources disseminated to the teams. All right, well, with that is all from me in terms of content. I know we're kind of 8 minutes from the hour. Sivane, I'll pass things back to you and then definitely open to questions through the Q&A if anybody has any questions at this point in time.
Thank you, Maria. We did receive a few questions related to if this webinar recording will be available on the Care for Caregivers website. Yes, it will be available for everyone early next week. So you can go to the Care for Caregivers website on their on-demand webinar section, and that's when you will see this recording moving forward. Other than that, I haven't seen any other question.
Oh, wow. Okay. This is not a question, but I've just had somebody in the chat say, just wanted to say thanks from Boston, Massachusetts. This was a great webinar. Very cool. Thank you for joining us internationally. I don't think I've ever had an international webinar participant before.
Yeah. Okay. Let me just share my screen.
Awesome.
Oh, wait.
And as Siboney is closing up, I'll continue to watch the Q&A if any last minute questions come in, but otherwise I think we can kind of start our close. Oh, agreed. Thanks from Vermont. Very cool. Yeah, awesome.
Perfect. Just give me a sec.
Oh, from Louisiana. My God, there's so many people from the States. Very interesting.
Yeah, we promote this webinar abroad, different channels.
Awesome.
So I see. Yeah.
Oh, looks like Siboney, I have a question here. What do you recommend for folks who might be having general life struggles, not a crisis? The great thing about this model is that it really does bridge across that whole continuum of crisis, like we kind of touched on at the beginning. So when we talk about general life struggles, the degree with which somebody's entering or the intensity with which somebody's entering that situation might vary, but the power of that listening tool is really going to be applicable across spectrums. And so when we think about those general life struggles, one thing to keep in mind, particularly when we're in a work capacity, is what's the role that we can play as an employer or as a colleague. Maybe it's not appropriate for us as a manager, for example, for me to pry into the details of my employee's divorce, say. But maybe if it's a peer, maybe you do a lot of listening. As an employer, really would recommend the same, though, noticing when somebody's struggling, asking how they're doing, listening to some of the feelings that might be coming up for them, but ultimately making sure they get bridged to that further support so they can kind of resolve that situation. Yeah. Hard when you don't know who to refer them to. Yep, definitely. There's some great, it's tricky without knowing where folks are, but I know in British Columbia, we have something called 211 that I know is in a number of different provinces in Canada. Not sure what the equivalent would be in the US, but it's a 3-digit number you can call. They also have a website that has a resource directory that gets updated regularly, and you can actually search by keywords as well. People who are constantly coming for you to help. I see. Okay, so there's another question about how to maybe deal with folks who are repeatedly coming to you for help. I think it would depend for me, the answer to that question, on kind of what your relationship is to that person. So if it's a patient or a client and there is that ongoing helping relationship, it's likely that there's some degree of necessity to respond time and time again. So I would say in that case, absolutely making sure that we're taking care of ourselves and setting boundaries where needed, but that we're able to kind of engage with that person within our professional capacity. If it's somebody where you don't have a formal helping relationship, and for example, maybe it's a colleague or an employee and it's bordering on an inappropriate relationship, you're like, I actually can't be that person to you. Really encouraging some compassionate boundary setting there. And this is my quick and dirty on compassionate boundary setting. Often I acknowledge the need first. Wow, I'm really grateful you felt comfortable reaching out to me. I'm really hearing that you're in need of support right now, and I can't imagine how isolated you might be feeling. Setting the boundary, unfortunately, as your manager, there's limits to what I'm able to support you with. However, and then providing that alternative, I want to make sure you get connected to the support that you need. And so let's look at who you can contact instead. So again, it's almost like the feedback sandwich, if you've heard of that before, but it's like acknowledge the need, set the boundary, and then offer that alternative. Yeah. All right. Oh, and one more question. Do you have training you can provide to all healthcare providers in emergency services? Do they take assist training, et cetera? That's a great question. They don't at the moment. I will say honestly that this is a dream of mine that I would love to see implemented. I know that some folks within, for example, I know the specific question here is about Island Health, so our health authority here local to the Victoria area. I know that there are folks who receive assist training within the healthcare setting here in Island Health. These types of trainings are not currently mandated to my knowledge and often are not integrated into formal curricula. So if you go to become, for example, a physician, you're not necessarily getting assist during your undergraduate or your MD. We are working with the health authorities, though, at CMHA-BC right now on improving particularly care provided to folks seeking support for thoughts of suicide. So it is an ongoing, it's definitely slow moving work because it's a lot of kind of systemic and cultural change, but it's definitely on our radar and something that we're really kind of working collaboratively with government and with the health authorities to implement. Yeah, great question. I think we might have to cut it there. We're 2 minutes to the hour. So Simone, I'll pass it back to you, but thank you. These are some very thoughtful questions.
Thank you, Maria. I want to be mindful about everyone's schedule. So I just want to remind you about our upcoming webinars, October 25th, Healing from the Impact of Trauma, November 15, Understanding Substance Use and the Workplace, November 22nd, Mental Health at the Work for managers, having that difficult conversation with someone who is struggling. So please visit the Care for Caregivers website to register to those upcoming webinars. Please be aware that we have 2 more resources on the Care for Caregivers website, Care to Speak, which is a peer-based phone, text, and web chat service that provides free, confidential, and unbiased support, emotional support to health and social support workers in BC. And also we have our Care to Listen podcast episodes with stories of mental health lived experience shared by healthcare workers and professionals. So thank you, Maria, for presenting this model, which is ask, listen, and refer when someone is experiencing distress in the workplace from an empathy perspective. Thank you, everyone, for attending this webinar, and we hope this content provides knowledge and support on difficult moments when dealing with stressful times at work. Please take some time to answer our survey once you exit the webinar. Your feedback is highly important to us so we can continue bringing valuable content to you. Thank you again, everyone, and have a nice rest of your day.